Okay, we're going to start the afternoon session, which will feature a couple of speakers and then an ample opportunity to talk to the panel members, including our international speakers. Chairing this session is Professor Doris Young, Professor of General Practice here at the Department of General Practice.
Thank you, John. So, having had the international speakers, we thought the session after afternoon tea, we have to showcase what we've been doing in diabetes research in our humble, small Department of General Practice at University of Melbourne, for Simon and Kamlesh, and both of whom I've actually, when I was visiting in the diabetes meeting in the US and also overseas, I've met and heard both of them speak. So because of that, I thought, why don't we use the International Diabetes Federation Congress in Melbourne? And Irene Blackberry said, we should have a symposium, and then we should invite Simon and Kamlesh and to come to our Department of General Practice at the University of Melbourne. And I said, I don't know whether they'll come. They're such prominent international primary care researchers, and standing on the podium, on the same sort of, to me, on par with some of the diabetes specialists. We all heard about, people like Paul Zimmers and Jim Best and the other, I don't know, a lot of Italian mafia sort of names that I can't remember. Everywhere you go to a European Union, there's all these like paparazzi groups, and they're all smoking away, and I just thought what I just learned before was just amazing. But I also I thought after we finish, we might talk about collaborations if we get an opportunity to do that. So on behalf of the University of Melbourne and our Department of General Practice, we have a special group called General Practice and Primary Care Academic Center. So my overview is incredibly brief because I want to really introduce my two collaborators, Irene Blackberry and John Furler, who will present some of our work, and also to share with you just really a very quick overview. Because everybody, we know that diabetes management, overseas, they've got 90%, 75% with cough. But in Australia, I would say 80% of the management of type 2 diabetes occur in general practice in Australia. And we always believe, myself, John, our research group here at Melbourne, I believe that to improve the care and outcomes, people with diabetes, we need innovative models of care, which we've heard a few before afternoon tea, in the primary care setting that are effective, cost-effective, and ensure the findings of clinical trials, which most of them are done by specialists. The addition, this study, not your study, addition, but usually the studies that with acronyms, and never really translate to general practice. So I want to make sure that the findings of clinical trials, novel therapies, we don't follow the PPAR. Everybody prescribed the most expensive drug and GPs just follow with a drug rep coming to see us. I just don't think general practice should be working like this. We are not people who just have lots of pens. How much is a pen? It is insulting to say that the GPs would just see drug reps because we want to get pens. And I will give you big pens, much cheaper. And these big thick pens that you have to hold in your hand that you can't even write. And these days we all use computers anyway. Who knows how to write anymore? So novel therapies and all these guidelines, to me has to be implemented in the real world of the Australian general practice setting. Real world. Efficacy, effectiveness trial. Does it really work? And Simon showed us some of them. It's a trial negative, but does it work? Maybe bits of it work. So in the jargon, it's called translational research. T3 and T4. T1 bench, lab to bench, bench to clinical to community. So T3 to T4 research is what I always believe that our center should be doing. And when we do research, we have to engage with stakeholders. It's essential to influence practice and policy in diabetes care. What is the point of doing research? I know we have to publish, Simon and Kamlesh, we know we publish or we perish. And I know it, and I saw BMC family practice, and it bleeds my heart. Also, very hard to get to Lancet and BMJ, But on the other hand, we can disseminate other ways. So, yes, publications, but our target groups have to influence general practices and GPs. We have to also influence and work with endocrinologists, with practice nurses, diabetes nurse educators, the consumers. The practice has to influence the divisions of general practice that I worked with for over 20 years in my own role as the professor of general practice. And recently, of course, Medicare locals. Now, health policy makers, they fund us to do research. They pay GPs for doing research. They pay us to do chronic disease management. They pay us for some of you, for team care arrangement. They pay. And the funders. And we also want to influence Diabetes Australia, the biggest group that helped to educate and supply the glucose strips to our patients. So we need to look at research that actually target these groups. Now, this is just a very brief slide, which I think this is really an opportunity for us to show and tell our own practice, our own department. Our department actually has got divided into themes. Because we are generalists, we really cannot have the luxury of just Department of General Practice at Melbourne University only do diabetes, or UQ, Queensland only do one thing, or Monash only do primary mental health. We can't afford this. We have to do a number of themes. And in our department, we actually have a research team and theme, aging, chronic disease, and equity, and we call ourselves the ACE team. And we were very humble. But we felt it's going to be led by us. It's going to be called the ACE team. And John is the absolutely master of acronyms. And he said, we are the ACE team. And so, John, I led this group for a while. And then now John Furler is leading it. And he's going to talk to you about our research project after Irene Blackberry, who's organizing this whole symposium based on Irene Blackberry. Just want to show you, we've got pharmacist, Phyllis Lau. And we've got diabetes nurse educator, we've got a program manager. We also train researchers, what I call a research capacity and a stream. So down here, we work with the community, with Ralph Ordine, GP's director at Darnella, who will be on the panel. We're with Christine Walker, who's the head of Chronic Disease Alliance, and she's our consumer advisory sort of group in our department. We have got scholarly, these four are medical students. Our medical students have to do a whole semester in research, and we have got honors students doing Bachelor of Honors with us, master students, PhD students, and also a team approach. So this is just one snapshot of a team that do this research in the area, and we are working with diabetes and also looking at, particularly looking at aged care. And our collaborators, which you see later on, that we're doing research in this sort of area. It's not the discipline itself. It has to work with so many people who are experts. They has to work with us, which is a team approach. So we have worked with diabetologists, epidemiologists, psychologists, that's what Simon and Kamlesh was talking about, health economist, cost-effective, biostatistician to analyze the trials, and the consumer researchers, and many more. And we are moving into biomedical informatics. We're using online advice. We're looking at patients, whether they can use sort of the phone to manage them, and also their diabetes care. So to just highlight that doing research in our academic center requires a lot of work, a lot of money, and a team. And so I thought by showcasing a couple of pieces of work that we've been doing, is that I will introduce the first speaker, and that's Irene, Dr. Irene Blackberry. And Irene, we're just sharing two models of care that we've been lucky enough to get NHMRC funding, which is equivalent to MRC. And getting grants like NHMRC is really difficult in Australia. It's about 20% success rate. And to get it in general practice is even more difficult. So we're incredibly proud with years of hard work that we've got this. So we're going to present Irene's a medically trained health services researcher, and she's been helping us to run the PEACH study, and in a researcher in her own right. And she's going to present the lessons learned from a study called PEACH study, of which some of you might have heard. And again, I think it was John Furler's acronym, the Patient Engagement and Coaching for Health, the PEACH study, and of course, using the fruit rather than call it a cake study. I don't think I can survive by calling a study called cake, but PEACH sounds fantastic. So if you can join me to welcome Irene, who will give us the first presentation.
Okay, so first of all, I would like to acknowledge, obviously, the study investigators for the speech study. We have dedicated staff running the project who help us running this, and also the study participants, so the GPs, practice nurses, and patients taking part in the study. I would like also to acknowledge the funding from the NHMRC and some fellowship support for me and John as well. So what I'm going to present to you today briefly is the overview outline of the study and outcomes of the study. And then I would like to concentrate a bit more about the lessons learned, about how our experience, our journey in embedding these innovative models of care using practice nurse-led telephone coaching intervention in the real-world Australian general practice. So it has been alluded to earlier on by the two speakers that there seems to be a persistent failure to achieve glycemic and other CVD risk factors among people with type 2 diabetes. And this is partly due to what we call a treatment gap or clinical inertia, whereby there's a difference or there's a gap between evidence-based guidelines and what you see in usual clinical practice. And research shows that nurse-led telephone coaching support and self-management is one of the way or one of an effective intervention to actually reduce the treatment gap as well as to improve the health outcomes. But we do know that the evidence from the pragmatic real-world general practice setting is currently lacking. Obviously, you are aware about the aging population, and to tackle the burden of chronic diseases, the aging population, as well as the shortage of clinicians in the community, the Australian government in early 2000 provided some incentives for general practices to employ practice nurses to support GPs, busy GPs in general practice, and particularly in the area of chronic disease management. So the aim of the PAGE study is to evaluate the effectiveness of a practice nurse-led goal focus. So we use a goal setting theory, telephone coaching intervention for people with type 2 diabetes to improve glycemic control and compare that to the usual clinical practice in Australia. So I've given you the definition of general practice nurse here because I'm aware that some of you are from overseas, but that's the definition from APNA, Australian Practice Nurses Association. So this is the model of the intervention. So we use the adapted coach program. So the coach program, some of you in Australia have heard about it before, is a hospital-based telephone coaching program for people with acute cardiac event. So it has been shown to be effective in the hospital setting, but it's never been trialed in the community setting, nor with practice nurses. So our study used a cluster randomized design. So practice nurses, they are randomized in the intervention group, receive a 2-day coach training. And following the training, they were asked to deliver 8 telephone coaching sessions for each intervention patients. So following the coaching sessions that they used the paper-based pro forma, they would enter the data into a computer-based coach software. And then a letter will then be generated, sent to a patient, with a copy sent to the general practitioner. So the study, the follow-up is at 18 months. So this is the consort flowchart. We recruited 59 GP practices in Melbourne and Victoria. Each of the practices needs to have a practice nurse. So we collected baseline questionnaires, physical measures, and blood tests from 473 patients. So like I mentioned before, half of them are randomized into the intervention practices and half of them in the control group. So the mean cluster size of the intervention practices is 7.9 with the range of 4 to 20 patients per practice, whilst control practices mean cluster size is 8.2 with the range of 3 to 18. And we repeated the same measure, baseline measure at 18 months follow-up. This is the characteristics of the patients. So as you can see in there, people are older. So people with type 2 diabetes, they are older. About 40% of them are female. You can see in the quite a majority of them have at least secondary education or more. We have a small proportion, they are unemployed, but nearly 2/3 of them have a healthcare card holder. Diabetes duration is about 10 years, so they do have a long-standing diabetes, and they do have micro and macrovascular complications. So this is the biochemical outcomes at the 18 months. So if you can see here, the white line here refers to the baseline value, so intervention control, and the blue bar here refers to the follow-up value. So if you glance over it, you can see that both the intervention and control group have similar trends towards the outcomes. And if you can see, this is our primary outcome, which is serum HbA1c. You could see there's a reduction in both the intervention and the control group, but the difference is actually not significant after accounting for a clustering effect and the baseline HbA1c. We only see a trend, and this is favoring to the control group of HDL cholesterol improvement. We also look at other measures, obviously the clinical measures as well as the psychosocial measures, but due to time, I'm not going to present that to you today. You're more than welcome to read our paper that's published in the BMJ in September edition this year. Alternatively, I'm going to present this at the IDF on the Wednesday morning session. So let's look at the characteristics of practice nurses, because I think that's what seems to be relevant for this talk. So we have 70 practice nurses taking part in the PAGE study, 34 in intervention and 36 in the control group. The majority of them age 40 years and over, and they have a registered nurse Division I qualifications. A small number of them did complete the diabetes education certificate, and a very small number of them do actually work full-time. The average patients recruited by practice nurses, both in the intervention and control arm, was 7. We did a workshop early on with nurses from the intervention group, trying to tease out, trying to find out a bit more about some of the issues and challenges to actually implement these innovative trials in general practice. And there are 2 areas that seems to be prominent to them. The first one is around the technical and resource. So that includes poor computer skills on the nurses' skills, the infrastructure access and technical support, and this is at the practice level. And we do also observe a high staff turnover. The other challenges seems to be clustering around the cultural and the contextual. For example, the practice environment often seems poorly attuned to any changes in the practice nurse's role. And this is manifest as competing demands, frequent interruptions when attempting coaching calls, and difficulty having a dedicated quarantine sort of time for them to do this work. And practice nurses commonly work part-time, which makes flexibility, to make the coaching calls also difficult. The other thing I would like to mention is with the telephone coaching intervention is that they are taking a new role. The new role means that, they need to be a bit more proactive now, trying to engage patients over the telephone, and that's not something that they've done previously, as well as they do need now to be a bit more proactive to actually intensify the diabetes medication as well. So a lot of challenges that they need to do. So in the next 2 slides, I have 2 case stories to illustrate some of the complexities, some of the challenges that the nurses have faced, and I'll let you read this. I'll give you a couple of minutes to read this. As part of the process evaluation, we also look at the coaching performance. So as I mentioned before, that the nurses did take a record of the discussion that they have with the patients. So we look at, we look back at the forms, the paper-based forms. We found 730 coaching sessions recorded. And as you can see in there, about a quarter of them actually didn't receive any single coaching calls. So 730 coaching sessions only applied from 178 of the 236 intervention patients. So that's equal a median of about 3 sessions per patient with the interquartile range of 1 to 5. The time spent by the nurses per session ran about 30 minutes, and that ranged greatly from 10 to 120 minutes. So obviously, some patients require an extra support, more support, whilst other patients, you can have a brief conversation with them. And we also look at whether there's any difference, if you've been given a more intensive coaching, whether that would improve the outcomes or not. But what we only see is the only outcomes improve with intensity of the intervention were the total cholesterol and diastolic blood pressure. The 3 main domains that we asked the nurses to address in the telephone coaching session is the biochemical targets, the biochemical risk factors, particularly HbA1c, the lifestyle risk factors, so that includes diet and physical activity and smoking, as well as medications changes, so intensification of medications. So as you can see in there, from 730 coaching sessions, this light blue bar here represents the current status recorded. So this is basically an idea or some documentation to show that the nurses have indeed discussed or mentioned about this with the patients. So 623 out of the 730, so that's almost 90%. And that's similar to the lifestyle as well. Around about 90% of the nurses did discuss these 2 issues with the patients. And out of this 90%, you could see about 70% of them actually have the advice about change. So there's a specific change made by the nurses given to the patient to actually improve their outcomes. But if you look at the medications, you could see that it's a lot less than the other 2. This is only equals to about 70% of all the coaching sessions that we have looked at. Only 70% of them actually have the status about the medication recorded, and only 40% specific advice about change was given. We also look at some of the recordings of the telephone coachings that were made, and from that, when we analyzed them, we found 2 different ways, the coaching styles, we call it. The first one is called treat to target. So treat to target concentrated solely on the protocol. So you need treat to target to improve glycemia and other cardiovascular risk factors. And these treat to target styles had a more directive relationship with the patients. In contrast, the personalized care tended to focus on the psychosocial issues of the patients and seemed to have a more supportive relationship with the patients. So in conclusion, training practice nurses in the telephone coaching intervention implemented in a real-world general practice setting produced comparable outcomes in improving diabetes control and cardiovascular risk factors compared to usual general practice care. And we found that this lack of effect may be attributed to the low intensity and fidelity of the intervention, mismatch between a focus on medication intensification and lack of prescribing rights among practice nurses, and practice nurses competing clinic demands, lack of time and space to consult with the patients. Future research could explore the effectiveness of different models of care, including having an external versus an internal coaches, nurses with limited prescribing rights versus nurses with non-prescribing rights. So I will now hand over to John, who will discuss more about our work in diabetes care.
Thanks, Irene. Thanks very much. So look, I'm going to speak very briefly on a program of work that followed on from the PEACH study. And I'll make sure we've got plenty of time for discussion with the panel members. But the work I'm going to present really originates from those two research groups described there, mentioned there. There's a lot of people involved in each of the projects, the Stepping Up study group and the Initiation study group. So I certainly want to acknowledge those researchers and collaborators. So really, what we did after PEACH, I think, was we realised that the focus of the work we were doing was pretty broad, may have something to do with the lack of effect of the intervention that we studied in PEACH. So we went back to the drawing board and we really narrowed our focus onto a particular identified gap in practice around this issue of insulin initiation in primary care. And I think we've heard today that as the progressive nature of type 2 diabetes has been better characterised, and as the tsunami of diabetes is coming, we realise that this is potentially a particularly important issue facing practitioners in primary care and patients with type 2 diabetes in primary care. So I'm going to talk about a couple of studies around this model of diabetes care that saw a particularly enhanced role for the practice nurse, specifically in insulin initiation in primary care. So we've heard a lot about the background. We know that the majority of patients with type 2 diabetes care have glycemic levels out of target range. And while, as I said, we know that lifestyle and psychosocial interventions are important and self-management support is important, pharmacotherapy is a key intervention, is an important intervention. And in particular, we know that there are delays in starting and up-titrating insulin in primary care. So data from Australia and the UK there showing that the mean HbA1c level, and I tend to work in old units still, I'm afraid, prior to insulin initiation from the Australian study is a community study, the Fremantle Diabetes Study, the UK was a GP sample, I think, but showing that mean levels at starting insulin, 9.4 and 9.3%, so well out of target, well above target range. And that even people on insulin, 77% of people with type 2 diabetes on insulin still have an HbA1c above target range. So there's a failure to up-titrate and intensify treatment as well. So why would we particularly be interested in embedding that particular aspect of work in primary care? Well, one important reason is that if insulin initiation can be made part of routine diabetes care in general practice, then insulin initiation can become part of integrated holistic care for people with type 2 diabetes. And that's particularly important when their comorbidity and multimorbidity and psychosocial issues are so common in people with type 2 diabetes that the management of the technical work of insulin initiation ought to be really integrated with that aspect of diabetes care as well. But again, also there is this mismatch between the coming need as the prevalence of diabetes increases and our resources. And there's some data showing that the workforce figures for Australia, with over 1 million people currently diagnosed with diabetes, and we have something approaching 500 specialist endocrinologists in Australia, maybe 1,500 credentialed diabetes nurse educators, but we have over 11,000 practice nurses and over 23,000 general practitioners. So really, this work has to be located in primary care. It's simply a question of matching resources to need. So I'll talk a little bit about this development of our model of care for addressing that issue. And we followed a series of studies, starting with a small qualitative project and some theoretical work, moving through a development of an intervention or a model of care intervention and piloting that in a small number of practices, and that's particularly what I'll talk about. And we then moved on to a larger pilot, the initiation study. I'll mention that briefly at the end, that involved 92 patients. And we're currently undertaking an NHMRC funded cluster randomised controlled trial of this model of care for initiating and up-titrating insulin in primary care. Our work has been underpinned not specifically by psychological theory, but more by sociological theory
and in particular the work of Carl May, who's a sociologist from Southampton, who we've worked with. Carl has developed this theory of implementation called the normalisation process model, gone on to the normalisation process theory over the last 15 years with international collaborators, and you can certainly find out a bit more about it at that website. There, he has a very, very, very user-friendly explanation of the model and interactive sort of toolkit for using the model. But I just want to read out very briefly what the model encapsulates. It's a middle-level social theory of implementation, as I've said, and it focuses particularly on how new practices in healthcare become embedded in routine care, routine practice. And it has four main constructs, I suppose, or elements to its theoretical frame. And it talks about the way new practices need to make sense to people, that practitioners and patients, if they're going to engage with them, need to be able to see this as sensible or meaningful work. They see chronic illness care as work, really collective work, that people need to cognitively be able to buy in and engage with the work, okay? And that they need to then, I suppose, disperse resources around doing that chronic disease work in a way that enables and supports collective action. And finally, they need to be able to appraise that work and monitor it as it's ongoing. So that's really in a nutshell, the sort of theoretical basis that we use to inform this program of work. It can be used to analyse problems of practice or to design interventions or design implementation trials of interventions, but we really used it as a sensitising sort of schema as we went along on this program of work. So, the first project was a small qualitative study that we did with funding from our College of GPs here. And we interviewed 10 GPs, 4 diabetes educators and 12 patients, some of whom were dyads and triads. They actually worked together. And we talked to them about their experience of, if they were practitioners, of putting patients on insulin, success stories and what they might call less successful stories, what went on, what actually happened. And if we talked to the patients, we talked to them about their illness narrative, their experience of going on to insulin. And we talked to some patients who the GPs had nominated as helpful to talk to. They were patients who the GP felt ought to be on insulin but hadn't made the transition onto insulin. And the sorts of factors that we identified in that small study that were important to supporting insulin initiation in primary care were that whatever was developed, whatever model of care was developed, needed to take account of the diverse aims of diabetes care. And they can range from, as Irene characterised, that very treat to target, focused on glycemic sort of aim, through to practitioners who characterise diabetes care as one element of very complex biopsychosocial care, or very patient-centred sort of focus. So there's quite diverse aims. People see the aim of diabetes care quite differently, and we needed to be able to encapsulate or manage all of that. That clarifying roles and expectations around insulin starts and up titration was important. That in busy, chaotic general practice environments, you need a local in-practice system for delegating the work, I suppose, and managing the work at a system level. And there certainly was discussion in that study around a potential role for practice nurses. So we went on to develop the Stepping Up model of care, and with funding from the Commonwealth Department of Health, we tested that in a small number of sites, 5 GP sites, ranging from solo practice sites, community health centres, and larger sort of group general practices. Involved 7 GPs and 5 practice nurses, and a small number of patients. 18 patients. Each practice was asked to identify 3 or 4 patients to join in this pilot or feasibility study. And 14 of those started insulin. And we undertook a qualitative evaluation at 3, and then eventually with some funds from the Australian Diabetes Society, a 12-month follow-up of those patients. And we focused our evaluation around this, based on the normalisation process theory, how was our model of care workable in practice, and how was it integrated into routine care? So what was the model of care? There were 4 main elements to it. it placed the practice nurse and the GP at the centre of the model of care, I suppose, working together in partnership, and having a very clear system within the practice for the GP initially delegating some of the work around talking to patients initially to the practice nurse, and then collaborating around starting and up-titrating insulin, based on very simple evidence-based clinical protocols and tools, and with appropriate support in a hub-and-spoke manner, I suppose, if you like, from endocrinologist and credentialed diabetes nurse educator. And we introduced that model of care to our pilot sites through a very short, if you like, 3-hour training session. It was an evening session, and we introduced them to the evidence and the rationale and the background to the model of care. Spent some time discussing and clarifying roles and expectations, roles around the practice nurse role and the GP's role. Spent a very small amount of time on some basic motivational interviewing techniques, and introducing them to these clinical tools for introducing and up-titrating insulin. And they had a chance to have some hands-on experience with some of the insulin delivery devices. This was supported by a resource pack for the practice and the practitioner, and a comparable resource pack for patients. And as I said, in that model of care, endocrinologist and D&E support was provided remotely, initially by phone. And the simple up-titration algorithm, this is just to give you an example from the resource materials and the training materials we used based on the work of Davies. We had an up-titration tool where patients were started on an ultra-long-acting analog insulin, and then every 3 days the patients completed a fasting blood glucose level over 3 days, and contacted the nurse either by phone or face-to-face, and in collaboration the nurse and the GP worked with the patient to simply up-titrate patients according to those simple sort of steps there. And we had some very rudimentary but simple paper-based tools to assist practice nurse and patient. So this one is the practice nurse tool, and this is the patient sheet. So the patient would record initially their fasting levels, call up the practice nurse, and they'd discuss both lifestyle issues but also the dose of insulin based on that simple up-titration protocol. So very simple sort of tools. As I said, we had 18 patients in that small pilot study. There are their characteristics there, a spread of educational and employment backgrounds, and a spread of diabetes duration there. And they started with a mean HbA1c of 8.4 at baseline. But the qualitative evaluation is what I'm talking about here. So we went back at three months, and we had a workshop with the practitioners. We had a focus group with the patients and interviewed those who couldn't attend that. And at 12 months, we had an interview with about 2/3 of the practitioners and patients who joined in the pilot study. And there were two main findings. And the first one I've called mobilising generalist practice to the task of initiating insulin. So we identified the ways in which key core characteristics of generalist care were linked and integrated with the technical work of starting and up-titrating insulin. So the common characteristics of generalist care, for example, continuity of care. So there was clearly a link between the way a continuous ongoing relationship between a practice nurse and a patient facilitated and supported the technical work. And there's a GP talking about that. They quite commonly talked about the way it enabled them to manage other comorbid conditions, including depression. They talked about the way both the continuous and ongoing relationship and their generalist patient-centred approach enabled them to really deliver information and education at a pace that was really dictated by the patient. So it could be frequent, small amounts, whenever the patient was ready. And some patients took quite a long time to really make the decision to go on to insulin. So the practice staff were ready, in a way, at the time the patient was ready to make the transition to insulin. So, again, drawing on our theory, we felt there was some suggestion in our evaluation that this was coherent, meaningful work that both GP and practice nurse could engage in, and that the tools and the resources that we had provided seemed to support collective action at a system practice level. The other theme really that we identified were some of these tensions and barriers and challenges to the work. Clearly there was still some issue around negotiating appropriate clinical autonomy around managing medications, and that scope and extending, and the confidence to extend, I suppose, work to scope of practice and really work right at that level of accountability for medication changes. So, and certainly in Australia, I don't think there's a strong tradition of practice nurses taking an active role, a proactive role in medication management. So we were really working at that sort of interface there. And again, particular to the Australian system, the time and funds involved in a fee-for-service primary care system, that needs to be accounted for somehow in how the work is supported. So just to finish off, we did then go on to undertake the initiation study, which was a large-scale pilot of this model of care in 22 practices, and 92 patients, with a combination of support from the NHMRC, CCRE and Diabetes Sciences, and some industry support. All of those patients commenced insulin. There was an embedded trial of continuous glucose monitoring within that study, which I'm not talking about. But the mean fall in HbA1c in those 92 patients was 2.6%, and the results were benchmarked against a nearby tertiary centre, and they were equivalent. And we're now, as I said, undergoing, in the middle of a larger cluster randomised controlled trial involving 74 practices and 224 patients. So I think that, in conclusion, this small pilot of a theory-based model of care showed that an important gap in practice can potentially be addressed through quite a simple educational system change and support intervention at a practice level that particularly targets the routines of care and the current roles and relationships that really provide the context for diabetes care in general practice. And I do want to emphasise that this was an inclusive model of care. We certainly are not suggesting that there's no role for diabetes nurse educators or endocrinologists. We see an extended 4+ member team as very appropriate, and we have endocrinologists and DNEs on our research group. So a final slide. In summary, I think that MRC framework, which provided us really the background for our series of projects, does provide an important framework for developing workable interventions that can potentially change practice. Our theoretical base was certainly very helpful to us, and our qualitative and pilot work has certainly informed our subsequent work. I think to develop new roles for practice nurses, they can't simply be tacked on to old roles. I think that the PEACH study showed that, and our pilot has shown that you're going to need to, even if additional resources can't be found, resources are going to need to be redirected appropriately. And I look forward to a growing capacity for clinician researchers amongst the growing practice nurse community in Australia. So thanks very much.
So while we can have a panel for discussion, so if I can invite Kamesh, Simon, now they come up and introduce Professor Elizabeth Patterson, Professor of Nursing in our faculty, and also Ralph Ordine, GP Medical Director for Diana Medical Community Health, and GP who actually has worked in research, participated in research, and he knows what it's like. He's employed as nurses. And Elizabeth Patterson's PhDs are looking at how practice nurses, what's the role of practice nurses in chronic disease management. So the reason why for Irene and John, because they just presented, and I thought for the symposium, it's actually better to bring two experts from UK who's done a lot of work and give you their feedback before afternoon tea. Then we present two projects, which is quite quick, and it's not matter to asking the detail of the study, it's to say actually, in the real world of primary care research, we come to words like, what is it like for the GPs to do research? What is the role of the practice nurses? Mind you, in Australia, we do not have patient registration. So patients can go to see whatever GP they like. So you don't have your captive, we were so jealous in a way of that population that we have. Very jealous. And it means collecting data is incredibly difficult to look at how do we show that whether we do any good. But because Brown is also involved in the national collaboratives, how many of you have been involved in the collaboratives? So Australia is a land of multiple projects. Our governments love trying out this project, that project, that project, that project. And never have a cohesive program to say this is the way to go. So we are a land of multiple projects. We are a land of multiple divisions of general practice projects. Now we're Medicare locals projects, trying to have a national healthcare trust. It's not the trust, primary care trust. So with that background, I thought if people want to ask the study itself later, and I think John and Irene will be around, but I thought let's open it up. And I'll really talk about first for Elizabeth Patterson first. I think her study was looking at practice nurses and this new entity. In UK, we have so many different nurses. You can have nurse visitors for young people, for kids, for babies, for older, for home visitors. But in Australia, we have got, the nurses also got turf wars. We're also a very competitive environment. We also have turf wars. So in nurses, it's also very difficult, and we've tried very hard. So Liz, can you just firstly comment on a bit of the nurse and then I'll open it to the audience and save your questions and explain who you are and the questions are directed to the four panel members. So maybe there's just a quick comment about nurses.
I first became interested in practice nursing about nearly 20 years ago when I was looking to do my PhD and was interested in primary care nursing generally. And I happened to be put in touch with a professor of general practice from the UK. And he said to me, I'm really astounded that there are so few nurses in Australia that work in this role. You know, in the UK it's very different. So that's what started my interest. So back then there was only about 40% of the practices employed a nurse, and most of them were part-time. Now we've gone up to about 60%, and it's very similar to the UK. It followed a path of the growth in numbers has been because of incentives in funding from the government, and it seemed to be, I guess, cheaper to employ nurses to do some of that work. And then as time went on, so research would start about sociological things. What do these nurses do? You know, what sort of education have they got and things like that. And as the numbers grew, similar again to the UK, research started to shift to, well, do they actually make a difference? You know, we've got more of them now, and apart from being an assistant to the GP and getting people through quicker, do they actually make a difference to patient outcomes? So I think we're now getting to that more pointy end of what is it that they do and do they make a difference to patient outcomes. And again, similar to the UK though, a lot of the information that's coming out is more related to the time that nurses spend, particularly nurses working in research, spend with the patient that the doctors are unable to do. You know, this time thing. I can only spend 10 or 15 minutes. I can't get into all those issues around education, psychosocial things. The nurses involved in research projects have had the time, and obviously that can't go on. You know, funding won't allow this great length of time for nurses to spend. And I think, interestingly, the things that I've been involved in, the positive things that have come from patients have been about the psychosocial aspects. It's about not just the time that the nurse spends with the patient, but there's things like the power differential. You know, that the patients see the nurse as more on their level, that they can talk to about what they think are trivial issues, which in fact are not trivial at all, but they don't want to waste the doctor's time, or they think the doctor will think I'm stupid if I say this sort of thing. And it's around too, I think, the nurses being able to help the patients shift from that very external locus of control. I come into the general practice to get the doctor to look after me and my diabetes, to a shift to actually I can take more control about this if I understand a bit more about it. And the nurses spend a lot of time with them then talking about how can you make these changes within your life context that suits you and your family. So they're just some of the things I think has been happening. There's a lot more stuff, but I'll let other people talk.
Maybe Ralph, just a quick, being involved in research or as a general practitioner, working in a practice, maybe some of the issues that you feel facing general practice, engaging in research in diabetes.
Okay, so when it comes to engaging in research, I think it's time. We're not going to engage in research that we're not interested in. I mean, with the stepping up in the Initiate trial, obviously I love diabetes. I do a lot of work with diabetes, so it actually fit with the sort of within the framework that I was working. So, we were then willing to commit time, effort, and actual nurse time to actually doing it, even though, it involved collection of data and all those sort of things which we all hate doing. But the actual benefit at the end was actually seeing robust data come through about how well our patients were doing in a very systematic way. And, I mean, as you know, the stepping up protocol is now permanently embedded within our practice. So, as John would say, it's now usual care for us. And that's been a real great thing to see every GP in our practice, not just me, adopt that model of care. So, yes, it's hard in the beginning, but the rewards can be great.
Great. So can I open to the audience? Any questions you'd like to ask in the morning presentation? Plus any issues that you feel you want to discuss or share with the panel members? Yes.
I'd just like to make comment to our British doctors that one of the reasons that medications make such a small percentage of your diabetes cost is your medications are about 1/12 the cost of ours. If you look at today's Australian Financial Review, Sydney Morning Herald. Secondly, that we don't have a per unit cost tax on alcohol, although we'd like to, and you guys are moving towards plain wrapping. But really the most important point I wanted to make was that you're talking about therapeutic inertia and these guys get these QOF incentives, but despite that, you said they're going for the money, just give them £1, they'll go for the points, but how come they've still got that amazing therapeutic inertia with, with very poor time they're starting on insulin and moving on to a second or third agent? So to me, this is entirely doctor-driven. It's nothing to do with patients. In our practice, very low socioeconomic, average A1C is 6.9%, and we do use the practice nurse. So what can you do about that inertia, and how come those guys didn't take the money? Or did they take the money and didn't get the target?
Okay, so what I showed you, that when the QOF first came in, within the first few years, there were improvements in the proportion reaching a target of less than 7% and then 7.5%. So there was an improvement. However, what's happened now is the target is still 7.5%. We have to reach 50% of our patients with that target and we get the full payment. So it doesn't give you that flexibility that you should have. To get 50% is quite easy to get a 7.5% target. And so you've seen the new ESD ADA position statement that you should individualize therapies.
Yeah.
And what's happening is they're not looking at the patient, they're not thinking through, I think, not many of them aren't, is that this is a new patient, newly diagnosed, I should be going for a target of 6.5%. This is an elderly patient who's had diabetes for 15 years, they're 80 years old, maybe that person doesn't need a tight target, I'd be happy with an 8.5%. And they're not making those complex judgments at all. All they're looking at is that 7.5%. And to get that 50% is quite easy. And if you're not interested in diabetes, that's all you're going to go for. I don't know if you have any comments to that.
Yes, just briefly. We used to spend more on testing strips than we did on drugs, so the situation isn't so great in the UK for prescribing costs. testing strips, the trials in general practice have shown that they don't actually improve glycemic control and increase worry and anxiety. So the other thing I would say is you can actually achieve good levels of glycemic control with cheap agents. Insulin I wouldn't regard as a cheap agent. So the therapeutic inertia in relation to starting insulin, I think, is something quite specific. And it comes from not just doctor-led, but I think is also patient-led. It takes quite a lot to encourage some patients. In Denmark, there's a completely different tradition. As you know, Denmark is one of the places in the world where insulin was manufactured, or first manufactured by Hagedorn. And so the culture there is of starting insulin much earlier in the disease trajectory. And so GPs will stick needles in their legs right from diagnosis to show the patient that it doesn't hurt. So I think there are many issues relating to that therapeutic inertia, and I think cost is probably only a relatively small one. I mean, in relation to the trial you just showed, I think that was very impressive, and the evidence for sociological theory around change management, I think, is a lot stronger than the evidence about, say, theory of planned behaviour and change in an individual's habitual behaviour. So I think I wouldn't want you to chuck the baby out with the bathwater and say theory isn't good. Theory is good, and theory is a lot better than what we had before, which was doctors telling people what to do and people not doing it. And in the case of the sociological theory and change management, I think that's a much more robust evidence to draw from. So I commend you on that. My only comment was, now that you've got GLP-1 drugs, where the concern about hypos and the initiation is much simpler, whether that approach is going to be less used in Australia.
In West, I was very impressed. The mean HB was 8.4% when you initiated insulin. But in the UK, we wouldn't talk about initiating insulin.
Yes.
Hi, my name is Irene. I'm a credentialed diabetes educator. I'm working in general practice in Australia. I have done for 3 years now. We work in a very large team. A couple of things that the session this morning that stood out for me was one of the comments that the size of the practice determines a lot of scope of the practice ability to engage in systems interventions. And I think that's very, very true. It's very difficult for a small team to accomplish large systems and outcomes. A couple of things that also came up was the nurses, the practice nurses and their roles, and their ongoing change and acquisition of skills and responsibilities. There's a lot of movement in this area. I don't know if anyone from APNA is here. Is anyone here from APNA present? Any
Practice Nurse Association.
So there's a 10997 code which nurses can get, and there's only 5 a year unless they're Aboriginal and Torres Strait Islanders, and they can get another 5. And so looking at policy for that to improve, and then that cost to go up from $30 or to $17 to $18, and not for that to be removed, which was at threat last year. Care planning is not a message of money making, it's a message of engagement in a preventative wellness mode. So it's not to have the patient in there to rip up a care plan and putting you to the doctor sign. Nurses are actually engaged in a lot of very good quality work there. I talk a lot I speak a lot and I talk a lot and I write a lot on this subject, and so I get this overwhelming sort of negativity that nurses are often, pushed in all these areas and not utilised correctly and not schooled efficiently and effectively. And I think that really needs to be looked at, and it needs to be cited with evidence. And there's a lot of area that needs to spend a lot of time in Australia developing, because there are all sorts of evolving models of care, and it's quite exciting, and there's a lot of structure to it. Research assistance is prevalent. Nurses, there's only 0.3% of nurses that engage in research. I can't decide right now. That was about 4 years ago when I presented on that. But giving the skills, like yourselves, primary healthcare research teams in other universities. I belong to one in Wollongong. The initial workshop we started off with had myself. I was the only practice person who was a CDE. My background is ICU, rural medicine, and a whole bunch of other things as well. And they're all doctors. And we just had another workshop, and we have a lot of practice nurses there, PTs and so forth. So we're growing in culture as well as far as inclusion of other healthcare providers. medical prescribing, if you look at the APRA guidelines at the moment, which are under review. So there's a lot of contemporary things happening, and I think that when we speak on these subjects, we really need to, every little point that might seem just perhaps anecdotal or a comment is actually needs to be carefully reviewed, because there's a lot of activity, and I think there would be a lot of feedback if we had other members that were involved with that. I hope
I thought maybe just to get a response a bit. I think we are hearing what you're saying. Maybe just a quick response from the...
We comment on two things. One is your issues were about models of care, and one was regarding research. In terms of models of care, it is evolving, and size of practice does matter, because that I showed you the points for diabetes, but then there's points for COPD, there's points for depression, points for asthma, points for CHD, etc. So if you've got a single-handed practice and they have a nurse who works 15 hours, 20 hours, she can't be an expert on everything. And that's why they're going for a model where you want to have larger practices, super specialized nurses. So we will have a practice nurse who deals with COPD, another practice nurse who deals with diabetes, etc. And that's the model we...
But there are models in Australia that do that. So that's
yeah. The other model is, I don't know, do you have healthcare assistants? Healthcare assistants.
No.
So we have...
This is the primary criticism of the healthcare system.
Right, so we have a healthcare assistant model now.
Healthcare system or system?
What happens is, so what happens is that chronic disease care, the GPs were getting too busy and there was too many of them, and so the work is devolved to practice nurses, and you have to make sure that that's managed well, such it doesn't look like the nurses are doing the boring bits and the GPs doing the exciting bit. But then after a few years, what happens is the nurse used to take the blood for the patient before they're then seen a week later by the nurse and the doctor, so you have all the blood test results. So that role is now being taken by healthcare assistants who are cheaper still. So a healthcare assistant is less expensive than a nurse, who's less expensive than a GP. And I dare say in 5 years' time, when someone comes in to have some other aspects of nursing or medical care, there will be somebody below, so to speak, in this hierarchy, the healthcare assistant. So I suspect that the direction of travel will be not dissimilar in Australia over the next 10 years.
The healthcare assistants do a lot more than just take bloods.
They
will do all the measurements.
Yeah.
Right? They will even give all the leaflets, diet leaflets, etc. And then they will go to the nurse for giving the appropriate advice, and our nurse prescribers will prescribe as well. And then if it's more complex than that, they may come to a GP. But in some practices, the nurse is the specialist, not the GP.
We also have that in Australia. I mean, they're called med techs.
So what's happening here too? Yeah, they've got physician's assistants.
Yes.
I'm going to say something about the small versus large practice.
And
When we say
Ralph's done many different types of
we've
practices.
had studies, and sometimes it's actually easier to make an intervention in a solo practice and get better results than it is in a larger practice. So I think, yes, you might have a broader scope, but some of the outcomes we see from a solo GP is absolutely fantastic, provided they're resourced appropriately.
There's going to be some of the best practices.
Yes. There's a gentleman over there, and I'll come back to here. Yeah.
In the most catchment area.
Yes.
Yes.
This is studies where he's trying to implement something like instant initiation in the GP practice and so on. I'm curious to know how those GPs or practices were selected, because I imagine you talk about upskilling and empowering GPs and disseminating the information. I think that's fine if you have to engage and interested people see that as part of their role, and they just need competence or need some information to do so. But also, I'm mindful of the fact that there is a wide range of practice styles, pressures, time pressures, and one of the ones we spoke about, clarifying roles and expectations, and there's a wide range of interests and where the GPs see themselves in terms of, like, diabetes, go to the hospital, that sort of thing. Not all of them, so I guess if you are sort of people engaged in GP practice or interested, this will work very well, but there's also a wide range of other people out there. How would you get them engaged and see that as part of this role? Because I think there may be disparity between what is set up to be, this is where diabetes should be managed, and what maybe people see as their turf out there.
So John, can you answer the question? How did you pick the practices?
Oh, that was only a small pilot study. They were selected by promoting the possibility of engaging the study to the local division general practice. And people put up their hands.
People were
There was,
Yes, we're
that was
already
a-
interested in
that was a
diabetes.
feasibility study, wasn't it, a randomised generalising study?
So how much? I think you've got fantastic results there. So I want to know how much training did these practices have?
They received 1 3-hour session.
That's it.
1 3-hour
To initiate
session,
insulin.
pretty
And
smart.
titrate as well.
Yes.
So to me, that's astonishing. Nice. I mean, I would be worried personally to get my GP practices to start insulin just with a 3.5-hour session.
Well, we can leave that for debate. There are many hands up. So maybe we can talk about this. I have this gentleman here.
This Scratch Carrington from the World College of General Practitioners. This segues from the other question, is around the engagement. So is it a combination of skilling the general practitioners to a higher level? Is it incentives as in monetary incentives? So is it just really trying to find people who are passionate? How much does education go to engaging in quality practice on both nursing levels and general practitioner levels? Was it really just the person? Was it the money we pay? Where's the divide here?
All of the above. It is everything.
Well, I think the things in general practice diabetes care that define good quality care and good quality shared care are audit, feedback, education, guidelines, payment, incentives. So
Just coordination of all of the above, including the practice nurses, is a fault of our system.
But I think one of the big differences that you highlighted earlier is the register recall system regular review. And if you don't have a register and a defined population, so the thing that drives this is data. And if you don't have data for your own patients and your own population, and then the people paying you don't have data on your performance based on the outcomes for your patients, then it's quite difficult to manage that system. So, and I understand that changing that would be there'd be some resistance to changing that over here, I should imagine.
Yeah, I was just going to say, I think practice nurses are no different from any other group of nurses in that there are a certain percentage who want to work at the top of their scope of practice, are really keen to do that, will seek out education, will take every opportunity, will engage in research and all of those sorts of things. I think one slight difference with practice nursing is still to date most of our entry to practice programs, and we've got one here, do not spend a lot of time on primary care nursing, so they don't get much exposure. I think there's still a lot of an attitude around that you go into practice nursing once you've finished hospital nursing and you go into something different, so they tend to be the older ones. So I think we've got a lot of work to do in the initial preparation of nurses and then ongoing education. Most of the programs around the country that was specifically for practice nursing have all folded because, well, there isn't the financial incentive to date for the extra education, and within the general practices themselves for nurses to take on expanded roles, there isn't the financial thing. So there's a number of different things I think that are influencing the roles that nurses would and could take on in general practice.
Yeah, just first of all, in terms of practices taking things on, it is incentives that is driving in the UK. Obviously, you do need the interest in things. But there's a word of caution. We've now getting to a level that we've got saturation. Our doctors, our nurses are not willing to take things on because they're inundated with work. They are working 8 to 8. The golf club days are gone now. Literally, you can, for the first time in the 23 years I've been there, I'm seeing people who really good practitioners who are saying that's enough, we can't take any more of it. And in terms of practice-based research, if we have to do an intervention where the practitioner or the nurse has to deliver it, I'm going away from those type of studies now because it just isn't happening. Because they haven't got the time. I'll just give you an example. We had a funding to do a study where patients came in with a risk score and then they had to present a high risk score to the practice, and the practice would get an incentive to do an oral glucose tolerance test. And the incentive was £45. £45 for the nurse to do an oral glucose tolerance test. Now we calculated that per hour it would cost £10 for that nurse if they were doing it. But we incentivized it a lot more, and we did not reach. We only reached 10% of our target because they said we just haven't got the time to do that. It's just a word of caution about research in primary care.
I'm an endocrinologist and I work in metropolitan Melbourne, and half my time I work in rural Victoria. And I think that there's a lot of issues in relation to fragmentation of care, coordination, even our medical reimbursement as doctors, which really are major obstacles, I think, in getting good care. I have to say, I'm in total agreement with your Venn diagram that these patients who have both specialist and GP care that get the worst care, because there's always this tussle of not offending each other as to what we do. But I'm actually fascinated by your possible model of, in fact, specialists working within community practices, which I think is fantastic, and I've actually tried to do myself, but I just find that the reimbursement issue of my ability to do that in a general practice makes it, well, at least in Australia, I mean, it may well be different in the UK, and I'm interested in what your experience has been in the model of care.
Okay, so there's two ways these models of care work. One is where the hospital consultants come out into the community. So they run a clinic once or twice a week in the community. The practitioners would refer these patients to that community clinic. The tariff for the consultants is less than patients attending the hospital because they will charge a lot less. And within their job plan, the consultant's job plan, they have to do 2 sessions in the community.
It's a contract.
It's a contract, that's right. There is another model where the consultant is a community diabetologist. So we've got some areas where they do full-time work in the community. And what they do is they run some of these clinics, but more so than that, they will visit each practice and go on a regular basis and look at complex patients and manage them at the practice.
In the general practice?
In the general practice, yes.
Hi, Chris Michael from
I can't remember where it is.
It's late. To add to the endocrinology, we've actually got a model like that in Queensland and Toowoomba, where our endocrinologist public goes out to general practice to declutter her own outpatients. And it's proven to be effective. So that was the one support that we actually have got that does work. The second is a statement, and I'd like you to give me an opinion. There are lots of models of care, and we always hear about the models of care that work. We never hear about the models of care that don't work, so we don't try and replicate them and find out that was a waste of time, someone's already done it, they didn't tell us that it didn't work. And if there are that many models of care, and it's like motor cars, all of us will try and drive to a motor car, it'll still do the same thing, it'll get us from point A to point B. Isn't really what we should be doing is designing models of care and then linking that model of care to the practice that best fits?
Yeah. You're absolutely right. In terms of models of care, I've presented 3 or 4 this afternoon. There are no randomized controlled trials of models of care except one. We've completed one recently. This was an intermediate care clinic based in a community where patients would be referred. And I'm sure I'm not out of order here by saying that the results were that outcomes were similar for where patients were referred to the hospital compared to the intermediate care model, but it was more cost effective, as you'd expect. But there are so many models that you could test out, or hybrid models you could test out. I don't think we're going to get many randomized controlled trials of those, and so you just have to look at best practice. You'll have some data. Partha, for example, the first model, Super 6 one I showed you, they're collecting data, and there's some positive results coming out of that. We're collecting data, our data will be over 3 years looking at our model. So you'll have some observational data about what models are working, but you won't get the randomized controlled trial evidence, I don't.
I don't know if anyone in the room is from New Zealand. Is there anybody New Zealand else in here they can back me up perhaps? New Zealand, yes. I'm not actually here as a clinical person of any sort. I'm here as a consumer of services, including control of my type 2 diabetes. it's been very, very interesting to listen. And the gentleman over there was talking about models of care just before, and you're talking about that. Well, there's an increasing turn in New Zealand amongst, I should perhaps just briefly say, we have our Ministry of Health, we have our district health boards, and there's about 27 district health boards around the country. The district health boards run the local hospitals. They also provide the funding to what are called public health organisations, to which every person who is in New Zealand must be registered with a public health organisation. You cannot attend a doctor. If you attend a doctor and you haven't registered and you're not part of a public health organisation, it costs you a considerable amount of money. Now, the DHBs, through the public health organisations, fund the GP practices for certain things, amongst them the diabetes care, what used to be our diabetes annual review, and it's just been changed over the last 12 months or so to diabetes and cardiovascular review, because there's, of course, we all know that there's a big correlation between the two. We just had published in the newspapers recently the last quarter's facts and figures or percentages, and the DHBs publish them all around the country, and you can look at these lists and you can tell which of your DHBs is actually coming to the party about diabetes and cardiovascular, asthma, all sorts of things, and they publish all their levels, and they will give them up and down arrows if they've bettered themselves or they haven't. But the PHOs, and from them, the GP practices will actually be financially penalised if they don't reach targets in an acceptable time frame.
Fascinating. There's another hand here. Yep. Maybe I'll comment, and then we'll do the timing. I think there'll be more questions that we can see if we can answer them.
We can move the discussion on in an informal sense after.
Yes, but I think people are not yet leaving, so I think we should continue a little bit. If you start to leave, I will stop it. There's always the 4 o'clock note. If people are sitting here and they're willing to make a comment, it is a symposium, it's terrible weather out there, just continue. Go on. People feel free to leave if you have to.
This Irene, central diabetes care here in Melbourne in private practice. I'm just interested in the UK model, looking at your GPs, your practice nurses. Where do you have specialty nurses that fall within, are they attached to the GP practice or in the hospitals?
Again, it varies. So they're called diabetes specialist nurses, DSNs. They're not the same as nurse educators. So DSNs look at complex patients. Usually, if a practice isn't going to be initiating insulin, if they haven't got the competency of initiating insulin, we would send them to the diabetes specialist nurse, who would start initiating insulin. They also look at more complex patients with hip problems and things like that as well. So they're based in some areas. They're based in the hospital, but they come out into the community. That's right. In some areas, they move from practice to practice, but it's mainly community-based.
Yeah. Any other questions? Maybe I'll get somebody else there first. Yeah, and then come back to you.
Kevin Walls from Melbourne, credential diabetes educator. I'm just interested to know whether you've looked at long-term outcomes of insulin initiation with credentialed educated versus a practice nurse. So credentialed educated with 1,800 hours of training versus the practice nurse with 3 hours. Whether or not there's more incidents of hospital admission for hypoglycemia or any detrimental outcome, given that most hospital admissions are for medication problems. Most hospital admissions for medication problems are to do with either insulin sulfonylureas or an anticoagulant. So whether you've looked at outcomes.
There are no randomized controlled trials looking at that as far as I'm aware. The only randomized controlled trial I'm aware of is hospital doctors versus GPs initiating insulin. So the titration algorithm you've used by Davis, that's from the Atlantis Glargine 202 titration algorithm. And we did secondary analysis of that. Melanie and I worked together from the same unit. So we looked at hospital versus GPs, and the outcomes were similar. So whether GPs initiated insulin or hospitals initiated insulin, hospital doctors, specialists initiated insulin, the outcomes were similar. I'm not aware of any regarding educators.
Could I just make an observation here that Julian Tudor-Hart was right, that diabetes and chronic disease management is largely about doing simple things well for large numbers of people, few of whom most of the time feel ill. Now, if you've had 1,800 hours training, you're going to be a far better practitioner than someone who's had 3. Okay.
One would like to think.
No, well, I mean, it's self-evident. But for most people with diabetes, the 1,800 hours versus the 3 hours probably doesn't make a huge difference for most patients. If you're talking about the subset with complications, then of course you can make an enormous difference, maybe even a life or death difference. But for the vast majority of the 500 million people in the world who will have diabetes in 2030, most of it is about doing simple things well for large numbers of people, few of whom feel ill. And the issue is about getting the highly technical, skilled delivery that you're describing for the people at the appropriate level of risk, so that the health service isn't bankrupted by highly skilled, highly trained, expensive people delivering care for people who are at relatively low risk. So it's about matching the skills and cost with the risk of the population. For most people who have the serious adverse outcomes in diabetes, they are the defaulters. And they're defaulting from care from a practice nurse with 1 hour's training, just as much as they're defaulting from care with someone with 1,800 hours training. So that the main cost is in defaulters who are getting no care. It's not about getting brilliant care versus almost brilliant. It's about no care versus some care.
So what I'm going to do, given the time I've been given a wind-up by John, so I will have to, he said, so I have to wind up, and feel free to ask the panel some questions because they're here during this hour block.
Just before Doris finishes, I should say there is some more food and drink out there if you want to carry on the discussion informally.
Yes.
You don't forget your evaluation form, and I'm happy to talk to anyone